Welcome to Conveed House. You may now have made your way through the 4 introductory lectures on pathology that form part of the movement and musculoskeletal biology module for second year students, and this is the revision session and non-interactive quiz. When the lectures were given live, it was an interactive quiz with voting buttons. Obviously that does not work. Anyone who logged on to Zoom for the live broadcast of this session was disappointed, and I apologize for that because the technology just would not work. In particular, it turned out that it was not possible for me to see the audience, which rather defeated the point of any kind of interactive session. So the quiz will only work if you pause the video and then work out the answer and then go on to see if you got it right. This session has always been delivered over the years on or about the Day of the Dead, which in the UK is the equivalent of the Feast of the Holy Souls in Purgatory, which actually fell yesterday on the 2nd of November. And the introductory slide is a textile celebrating the Day of the Dead, which is of course the national day of those of us who work in the death industry. So without further ado, please take a look at this slide. It's a histology picture, and it shows 5 histological features of malignancy. What are they? The answer slide is mildly interesting because, operating on logical principles, I decided that as histo slides are purple, the writing should be in green for maximum legibility. In fact, I find it surprisingly hard to read it. It has the effect of one of these eye tests for colour blindness, but there you go. Probably the 5 best features to name are abnormal mitoses, that's the Mercedes-Benz sign near the middle, nuclear pleomorphism, the nuclei vary in size and shape, nuclear hyperchromasia, they are very darkly staining in comparison with normal cells, an increased nuclear to cytoplasmic ratio, the malignant cells are short of cytoplasm, and an abnormal chromatin pattern with speckling within the nuclei. Mitoses of themselves are not a particular feature of malignancy. Take a look at this. Do you think it's benign or malignant? And as they used to say in school exams, give reasons for your choice. It shows similar features to the previous slide, only in a more advanced degree. We also see here multinucleated cells and very marked anisonucleosis, variation in the shapes and sizes of nuclei and prominent nucleoli. What is this tumour? There's a macro picture of this all too common specimen on the left and a histology picture on the right. These are uterine fibroids or leiomyomata, benign tumours of smooth muscle. There's a very low mitotic count and the nuclei have a very monotonous appearance. Here is the end of a long bone. What feature of malignancy does it show? What features of malignancy are there? Well, metastases, it can't show that, and invasion. This is a chondrosarcoma and it's eroding through the cortex of the bone into the surrounding soft tissues. Here's a radiograph of the end of a long bone. List the characteristic radiological features of this tumour, and what is it? It's in a very characteristic site. It's an osteosarcoma. The area around the knee is the commonest site for this tumour. It shows opacity. It's radio-opaque, so it appears white on the X-ray, with lifting of the periosteum forming so-called Codman's triangle, and spicules of bone being formed outside the bony cortex to give the sun in splendour or hair-on-end appearance. Another tumour. Looking at these slides, you begin to get some idea of just how exciting histopathology is. What is it making and what kind of tumour is it? It's making this purple substance, which is osteoid, and that shows that it's an osteosarcoma. The commonest malignant tumour of bone is what? And what are the commonest sites of primary tumours that metastasize to bone? The second part of the question gives the answer to the first part away, because the commonest tumour of bone is secondary carcinoma. The 5 common sites of primary tumours that are bone metastasizing are lung, breast, prostate, kidney, and thyroid. These are the parts of the patient that should be examined if they present with multiple bone tumours. What abnormal features does the baby show? Year on year I'm asked if this is going to come up in the exam, and no, you are not going to be shown a radiograph of an abnormal baby and be asked to make a diagnosis. However, I think it's quite a useful exercise because it's interesting to see what abnormalities you can note, and it does make the point that the diagnosis in these cases is by systematic examination, listing of the abnormalities, and then matching those abnormalities against those commonly seen in various syndromes. This child has short limbs and a small chest cavity. The hypoplastic chest is responsible for its death, since the lungs will not grow to sufficient maturity to be capable of respiration. The short limbs show a characteristic curvature. The vertebral bodies are abnormal and U-shaped. This is a variety of thanatophoric dysplasia. Notice that the baby itself is dysmorphic. It has a long philtrum, a small mouth, low-set ears, some degree of hypertelorism. The fingers are quite widely separated. Interspersed in this little quiz are 1 or 2 case studies. The first one deals with an inflammatory condition. You remember the cardinal signs of inflammation: redness, pain, swelling, heat, and loss of function. Here they are in a knee joint. There has been septic arthritis, and this has developed into osteomyelitis, inflammation and infection of the cortical bone. We see that there's an arrow pointing to a sinus where the infection has partially drained, and that the knee has fractured through the infected area. Osteomyelitis can be very difficult to treat because it's difficult to get antibiotics into the bone where they're needed. Perhaps the commonest causal organism is Staphylococcus aureus. Here we see bacterial colonies within the marrow space of the bone. Now, fortunately rare, the last case I saw was in a patient with sickle cell disease who are prone to infection because they've had splenectomies and are prone to ischemia of bone because of sickle cell crises. At one time, osteomyelitis was very common, and because bones are durable, almost every pathology museum contains some examples. Here's a histology picture of tuberculosis osteomyelitis, at one time very common. It has the characteristic caseous necrosis, along with giant cells which are Langhans type, with a horseshoe of nuclei. As with all infections, the treatment is to drain it, a procedure best done aseptically. In this museum specimen, we see the characteristic appearances. There is a core of necrotic bone, and surrounding this is new bone growth, which forms a kind of cloak around the dead bone. So the inner dead bone is known as the sequestrum, and the outer viable bone, the involucrum. Here we have a femoral head. What's the matter with the femoral head? It has lost the articular cartilage from the surface. The bony surface is shiny. It has undergone eburnation. This is from a case of osteoarthritis. Here we have a femoral head seen in cross-section. What abnormalities can you see and what is the diagnosis? Here labelled 1, 2 and 3, we see erosion of the osteoarticular cartilage, cyst formation, and 3 is the articular cartilage itself. This again is a case of osteoarthritis. Another histology picture. What's wrong with this bone? It's fairly obvious that the trabeculae are thickened. The normal pattern of the lamellar bone is disrupted if you view it by polarizing microscopy. This could be Paget's disease of bone, or it could be reactive bony thickening in an osteoarthritic joint. A few words about Paget's disease of bone. Here we have Sir James Paget in the gown of a Fellow of the Royal College of Surgeons of England, discoverer of this and various other diseases. Paget's disease, a thickening of the bony trabeculae, most commonly affects the skull, the pelvis, the spine, and the leg bones. There may be a characteristic curvature or bowing of the tibia, and the skull becomes larger, thereby increasing the hat size. The usual way of diagnosing Paget's disease now is when you encounter difficulties sawing off the top of the skull at autopsy and you realize it was too thick. It often isn't diagnosed during life. What is the etiology of Paget's disease? Well, when I was young, there was a well-known American television astronomer called Carl Sagan who presented various TV shows, and on one occasion he was asked by a newspaper to write 500 words with the title, "Is there life on Mars?" And Sagan just typed out "nobody knows" 250 times and sent it to them. So the short answer to what is the etiology of Paget's disease is nobody knows. The slightly longer answer is it could be viral, it could be something to do with hypersensitivity to vitamin D, it could in part be due to somatic mutations. A number of viruses have been suggested, including measles and respiratory syncytial virus, and even canine distemper. So maybe there was some truth in this great classic of popular medicine, cancer is the dog the cause. Apart from the clinical picture, diagnostic clues are a raised alkaline phosphatase and hearing loss because the ossicles are not exempt and they will not function properly if they are thickened. Among the more serious complications is cardiac failure because the increased bone density carries with it increased vascularity and increased circulatory demand, causing the heart to fail. If we view the bone under polarizing light, it not only looks extremely beautiful, but you can see that the lamellar pattern of the bone is disorganized, so although it's thick, it's paradoxically less strong and prone to fracture. What are these cells viewed by polarizing microscopy in an inflamed joint? They are urate crystals in a case of gout. Here's a section from a joint showing rheumatoid arthritis. The inflammatory material, the question mark, is what? It's known as pannus. Here we see the end of a phalangeal bone, much magnified with white chalky deposits. This is a case of gout. Here we have a clinical picture. What is this? It is a gouty tophus, a chalky excrescence with which one could, should one so desire, write on a blackboard. The most common location for these is on the hallux. Here we see the crystals, needle-like crystals showing red-green birefringence, and here we see the characteristic histology of the tophus. Gout is now much less common than it was formerly. Apart from the changes in diet, it's also helped that hydration tends to be better, and therefore urate crystals have less opportunity to form. Those of you who have occasion to visit the Royal Free and who go up the hill towards Hampstead Station will pass this drinking fountain, which was placed by the Metropolitan Cattle Trough Association, and it says thereon, "The merciful man is merciful unto his beast." Although the Cattle Trough Association may seem like about the least controversial organisation ever, in fact it was disapproved of, because by providing free drinking water for humans as well as cattle, it was harming the business of publicans, because until the 19th century people routinely drank beer because they had no access to clean drinking water. This is a resected finger. What do you think is the tumour? It's a chondroma. It's a benign tumour of cartilage. It has been resected because it's a disfiguring mass impairing function. As the margin is relatively close, this would have been unlikely to be a procedure for a malignancy, which would have required a more extensive amputation. And here we can see the radiograph of the tumour during its period of attachment to the patient. And here we see a knee joint broken open with a bread and butter appearance, an irregular surface. These are signs of rheumatoid arthritis or rheumatoid disease. Here's an X-ray of a hip joint. What are the main abnormalities and what's the diagnosis? There's loss of joint space, osteosclerosis, osteophyte formation, and perhaps some subcortical cysts. This is a case of osteoarthritis. Nothing is more enduring in anatomical terms than bone, and one can study bones that have lain in the ground for a considerable period of time. I have been fortunate enough to have dealt with some cases dug up in the City of London. Here we have something far older. This is from the ancient Near East. It's over 2,000 years old, and it is a calcaneal bone from a crucifixion. Not the crucifixion, just a crucifixion. And this is important archaeologically because it's evidence that there was Roman civilization in the area of the time. It says something about your civilization when the evidence of it is a nail knocked through the bone of someone who was still alive when you did it. And here we see a skull with the characteristic pepper pot lesions of skeletal syphilis. Bony changes have been useful, for example, in supporting the Columbian hypothesis that the disease was unknown in Europe until brought back by conquistadors in the early modern period. Some dinosaur bones show changes of what looks like Paget's disease, leading to the suggestion that they were also plagued by viral infections, perhaps similar to modern measles. And finally, where is this? This is the Capuchin convent that's on the Via Veneto in Rome, and when we visited, the monks were very hospitable when my wife told them that I was in fact a pathologist with an interest in bone and not just a passing weirdo. Generations of monks have had their bones added to the vaults of the catacombs, where Mass is celebrated daily in the presence of preceding generations of monks whose memories are not forgotten. This now completes the series of bone and joint pathology lectures that were the introductory pathology series from the movement and musculoskeletal biology module. If you have managed to complete them to the end, congratulations and thank you for listening. Customarily in the live lectures, I would end with a few comfortable words. Medical students are often plagued with anxieties and apprehension about the future. Do remember that you are on a course where the pass mark is about 95% and the final examination isn't even graded, so none of your patients will ever know that you didn't do all that well. Also, there will be plenty of job opportunities owing to various changes in the National Health Service, including the improbable prolongation of the pension age, which has led many people of my generation to retire early. But all the same, I wish you very good luck, and from Essex, goodbye.